Looks like we have everybody here. Great. Thank you very much and for being here, all three of you. And in case our audience, some members or some of them are just joining us, hello and welcome to the medicine session of the Connected 2025 program, sponsored by the thyroid eye disease community, led by Christine Gustafson. As we have a global audience this evening, good evening, good afternoon, and good morning, depending on your time zone. My name is Carol Bowden, and I'm a thyroid eye disease patient and pharmacist. At various points in my career, I've worked as a clinician in hospitals, as a medical liaison in the pharmaceutical industry, and as faculty in various schools of pharmacy and major academic centers. I have thyroid eye disease for about 5 years. And of course, I have a keen interest in the medications used in the management of thyroid eye disease. Today, we will discuss some of these medications, the old, the new, and the potential future medications utilized in the management of thyroid eye disease. We hope to answer the most common questions that patients have related to thyroid eye disease. And joining me today, we have a distinguished panel of experts who can also answer your questions. Though I'll start out with some prepared questions, please feel free to enter your questions in the Q&A box at the bottom of the screen. And just be aware it's separate from the chat box. Look for the Q&A section there. And our curator will pose them at the end of the session. So let's dig in and get acquainted with our members of our panel, namely Dr. Brent Hayek of the North Georgia Eye Associates in Gainesville, Georgia, Dr. Deepak Ramesh at the Center for Eye and Facial Plastic Surgery in Somerset, New Jersey, and Dr. Brian Wynn at the University of California, San Francisco, and VA Medical Center, also in San Francisco, who also happens to be my surgeon. And behind the scenes, we also have as our curator for the Q&A session, Dr. Jeff Kent, who is of Sling Therapeutics. Can each of you, to begin, just share a couple of sentences about yourselves and your work in thyroid eye disease? And Dr. Wynn, I guess we'll start with you.
Oh, great. Thanks. So just a little about myself. I've been treating patients with thyroid eye disease for almost 20 years now, both when I was in New York and now in San Francisco. I'm very much interested in the interplay with all of the different therapies that we have now and really kind of understanding them. I kind of have a belief that maybe there's no single magic bullet, but perhaps, utilizing different therapies for different folks, tailoring it to them, potentially even using combined therapies, maybe a little bit more of the Holy Grail.
Oh, good. Well, we're looking forward to hearing more about that here later in the session. And Dr. Hayek, would you like to say a few words?
Sure. I've been practicing for about 16 years treating patients with thyroid eye disease. I've been in academics for 10 years, and now I've been in private practice for 6 years. I was one of the principal investigators in phase 2 of the teprotumumab trial. I have a strong interest in thyroid eye disease, and yeah, I agree with Dr. Wynn that, I don't think there's one single bullet. I'm kind of excited about potential new therapies coming out, different ways of targeting the immune system, and getting more people a lot better.
Great. Thanks so much. I appreciate your comments and excited to hear certainly the way you all three will interact. And Dr. Ramesh, if you could comment for a few sentences here too.
Yeah, my name is Deepak Ramesh. I'm in solo practice in North New Jersey. About 40% of my practice is TED. We run some of the clinical trials, and I think number one, it's really fun to be on this new wave. We're sort of exploring our uncharted territory as far as a groundbreaking treatment for an autoimmune disease that for, as long as we know, we didn't really have a targeted or, disease modifying treatment. So it was really amazing to be on ground zero of that, but also now we can explore the different ways we can add this therapy, as Dr. Hayek mentioned, combine therapies, and even now kind of dance in between medical treatment and surgery and back to really get patients the best result that they could not have prior to, 2020 or 2015 when these treatments really started being developed.
Oh, great. Thank you very much for that introduction. And now, as everyone's introduced themselves, let's begin with a few questions. So we'll start by the fact that we all know that steroids are frequently used as initial therapy in the management of thyroid eye disease, and we know that there are many side effects that can be associated. Dr. Ramesh, could you begin by telling us a little bit about some of the pros and cons of using corticosteroids for patients with thyroid eye disease?
Yeah. So in the current world, I think there are really only two indications for steroids, my personal opinion. And I see a few of my patients on the attendees list. So you probably have heard me talk about this before. The one main reason why someone should get steroids, I tell them you have to get steroids, is if they have compressive or dysthyroid optic neuropathy. Because per our research, the only randomized controlled trial that we have ever done as a field in dysthyroid optic neuropathy involves IV steroids. So someone is admitted at the hospital, they get 1 gram per day of high dose steroids, and that has a pretty good chance of treating the patient's optic neuropathy, I think 40 or 50%. So we know that steroids are indicated in that situation. Beyond that, steroids help people feel better. They help you look better temporarily. They have side effects that are well known. So, yes, you're going to gain weight. You might gain water weight. You might have trouble sleeping. Your blood sugar will go up, all of these things, but they're known side effects because steroids have been used for so many different diseases for so long that we're very comfortable with both dosing and how to manage the side effects that you get from it. So, um, really, the only other role where I use steroids is as a bridge to a targeted therapy like teprotumumab or another biologic medicine that's coming in the future. So you can give that as oral, you can give that as IV once a week. You don't have to do any of these things. I often like to give it as an injected steroid behind the eyeball because I feel like it reduces the systemic side effects while giving you the maximal effect behind the eye. But that really comes down to personal preference and what your surgeon or your physician really feels comfortable with and what's convenient for you. So there's no necessary right or wrong as long as we're not talking about dysthyroid optic neuropathy.
Mhm. Oh, great, great, thanks. Yeah, there are lots of uh, complications that can come about as a result of steroids, and certainly we're grateful that we have some other therapies as well that we might be able to use, including radiation, surgery, and we've had some questions on Botox as well. And Dr. Hayek, could you talk to a little bit about these three therapies?
Yeah, I mean, like in I agree with Dr. Ramesh, steroids, is like a shotgun approach to the immune system. It kind of blocks almost all pathways of inflammation. And as we know, thyroid eye disease carries a lot of inflammation as one of the key drivers of really the disease. It's either given orally, IV, or an intraorbital injection, and all three of these modalities can have an effect. Um, I think that because of the symptoms with thyroid eye disease in terms of pressure and pain and grittiness and all that associated with inflammation around the eye and then spills over on the surface of the eye, steroids can, make people happy and can really at least temporize the situation. Um, and we know that we can't really have people on long-term steroids without, these known side effects plus others, including osteoporosis and a lot more things. And thyroid eye disease, at least in the inflamed state for most people, it's going to be a couple-year duration. And so we'll have people on steroids for, a month or so. There's some protocols. Europeans use a lot of steroids. I don't find that they particularly work well for proptosis, but they do help with a lot of the inflammation. When I was at Emory, we also this is before Tepezza, we did a lot of low dose radiation. And, when you think of radiation, you think of it as, as an anti-cancer therapy, which is true, but lower dose, it can also target inflammation. Not very specifically per se, but there's some studies that suggest that particularly people with double vision um, or a relapse after steroids can have maybe a longer duration with low dose radiation. That can be a little bit challenging in, a lot of just rural communities, or if you're not associated with a radiation oncologist or a TED specialist that can set that up, because a lot of them don't treat thyroid eye disease. Um, does that answer the
Yeah,
question?
I mean, and if you can, I don't know if you can address any things related to surgery, or if
Oh
maybe
yeah,
you or
yeah.
the other panelists to Botox also. There was a
I'll
question on that.
briefly on surgery. Like,
Yeah.
we have a lot of people on Tepezza these days, and surgery is not typically an acute indication for thyroid eye disease. um there are three main surgeries for thyroid eye disease. That's orbital decompression to kind of help the eyes to go back in. There's eye muscle surgery to help realign the eyes, and there's eyelid and periorbital, around the eye surgery, particularly with the eyelid retraction to help lower that, and then also to make people look, more like they were before. Those are all done when things are stable, except for perhaps when someone has this compressive optic neuropathy. You can do more of an emergent orbital decompression to take pressure off the back of the eye socket for that.
Mhm. Great. Thank you. Thank you very much. Oh, did you have anything else to say?
Just, I guess, the Botox question that you had,
Yeah.
I think most people are using that in terms of maybe two indications, and one is for eyelid retraction. And so occasionally people will inject the upper eyelid to help reduce it a couple millimeters. And that's been shown to be pretty effective in individuals. And then some will use Botox for strabismus as well. So you can kind of paralyze one of the muscles. And, in certain patients, especially with smaller deviations, with smaller, strabismus, the effects can be long lasting.
Wow. Well, that's great to know that we're moving forward in research in that area as well. Thank you.
There,
And Dr.
there was a
Nguyen, I
question
just
about there's a question. Sorry, to interrupt. There was a question about, do steroids help to improve fibrosis? And I would like to ask Dr. Nguyen. I don't believe that steroids necessarily reduce the risk of fibrosis. What do you feel about botulinum toxin in the extraocular muscles? Do you feel like treating someone early who has a very tight muscle, paralyzing that muscle, might help reduce fibrosis? Or I just don't have a lot of experience with that.
Yeah, I honestly don't know either in terms of that aspect of things. There's a possibility I could posit that, if you're able to get people a little straighter in terms of their deviation, maybe they'll be less symptomatic, even if they're, you know, f- very fibrotic, and just might not have as much movement in general. So I'm not sure it would actually, and again, I didn't do those studies, so I'm not really sure, but I'm not sure if it would really affect the fibrotic element of it, but it may just affect the deviations.
Mm.
great. Thank you very much. And Dr. Nguyen, my next question is also for you. And that is, now that we've kind of covered some of the traditional therapies, the steroids, radiation, and surgery, albeit very briefly, we're just short on time, unfortunately. But at any rate, we'd like to discuss, turn to some of the newer biologics. And if you could comment on the biologic therapies, and this has a couple of parts to it. First of all, are the biologics truly halting the disease progression, or are they treating the symptoms? Please comment on the safety profile and the durability effect. So I know that's a mouthful.
Yeah, that should be like
And
spread out for all of
yes,
us
I know,
probably.
and hopefully all three of you can kind of comment on that eventually as well. So
I think
I'll let you
I
go.
lost the bet here.
Okay.
Um, so I guess maybe let's start with the fact that people started using some biologics for thyroid eye disease even before Tepezza or teprotumumab was on the market, and so people were using rituximab to deplete B cells. People are even starting to use IL-6 inhibitors, including tocilizumab, to decrease activation of the immune system um, before teprotumumab came uh, on the stage. But the first drug to really be FDA approved for thyroid eye disease was teprotumumab or Tepezza, and Tepezza is an IGF-1 or insulin-like growth factor 1 receptor inhibitor. And so it's an infusion, and there were two, very well done randomized clinical trials that looked, and maybe Dr. Hayek can talk to us more about that since he was a participant in one of them, that showed that at 24 weeks, um, you know, there was a significant decrease in proptosis of, on average, about 3.5 millimeters. That the clinical activity score plummeted. So this is that measure of inflammation, including eyelid edema and eyelid redness, conjunctival edema, conjunctival redness, caruncular edema, pain behind the eyes, pain with movement. Um, and as well as diplopia. So when people, were really symptomatic from their double vision, many of the patients actually improved in terms of their symptomatic diplopia as well. And this was sort of at 24 weeks. So, and the, treatments were set up where the standard treatment is you get a dose of teprotumumab via infusion every 3 weeks for 8 doses. Um, and, I think a lot of us, when we began this, we were like, wow, this is just such an amazing drug because it really reduces proptosis quickly and double vision becomes less symptomatic and clinical activity score. And, I saw people respond within a couple weeks to this drug, often after 2 or maybe even 3 infusions. And it was tremendous. Um, the I think what we're some of us are learning now, and would love to hear from Dr. Ramesh and Dr. Hayek about it, is that as we've used this more, we've found that the durability of the proptosis effect and the double vision effect, especially, have sort of waned with time. So when we looked at sort of the follow-up data from the original clinical trials from teprotumumab, at 72 weeks, really only about 60% of those who had initially responded maintained their response. And so that, so if we follow them out, that a year and change, only 50% or 60% of those who responded, which is really just 50% of those who received the drug, um, kept their response. And there's been a couple studies now that are sort of suggesting that you follow patients out 2 years, um, only about 33% or so kind of keep their response. And where we initially saw that you could get 3.5 millimeters reduction on average, when we look at that 2 years, we end up losing on average about 2.5 millimeters of proptosis effect. And so we're getting that millimeter, millimeter and a half that we tended to see with steroids or with tocilizumab or with rituximab or with radiation and steroids. And so at the end of the day, maybe to get to your question of are we really changing the natural history or are we just kind of modulating it temporarily? Again, it depends on who you talk to, but at least in my experience and my practice and how I'm thinking about this is I think at least teprotumumab is probably modulating it more than modifying it long term. Um, and we're finding that a lot of patients who initially had a great double vision effect lost it and, still need to have strabismus surgery, or, they lost their proptosis effect and probably still need to have an orbital decompression. Um, and so what I think that a lot of the drugs are really good at doing is decreasing the clinical activity score. And I'm wondering if now really we should be focusing on that more than anything else. If we can drive down the inflammation and keep it flat and keep it, a clinical activity score of 0 to 1, um, for the duration of the disease, and then do whatever rehabilitative work we need to do, whether that's, strabismus surgery, orbital decompression, et cetera, that may be, where we're at the moment. Um, I do have thoughts as, we had such a robust effect from teprotumumab. Would there be a way to, maintain that with some other, drug to follow it, or some other modality to follow it? And people are looking at whether, after giving teprotumumab, could we give radiation and maybe maintain that effect? Or if we gave teprotumumab and then use something like tocilizumab or Actemra to sort of decrease um, the TSI and, keep the disease quiet from a autoimmune standpoint, can we maintain that teprotumumab effect, that double vision effect? And we just don't know. And that, I think that's where maybe some of the trials need to go in the future is, how do we maintain that Tepezza effect?
And kind of what combination of therapies might be optimal for each patient, depending
Yeah.
on the response. Dr. Hayek, did you have something you wanted to add to that or comment?
Well, no, I agree. Because even in the study data, a lot of people kind of had a rebound, particularly in the first year-ish. It generally overall, at least in that early phase or year long, patients still I think felt overall a lot better than before the teprotumumab. Kind of like Dr. Nguyen was saying, because a lot of the clinical activity, which really bothers people with the pain, the pressure, the gritty sensation, the red eyes, the swelling, a lot of that could subside and remain that way. And the proptosis can be bothersome for people. Sometimes not as much as, the amount of inflammation, unless it's a lot of proptosis. And they did have, an average of 3.5 millimeters, and they tend to get a bit of rebound. And so, yeah, I think that it is an autoimmune disease, so it's a chronic disease, and we think we were trying to put it in remission, so to speak, or even improve upon that. But I concur. I think that, a longer term strategy was, a targeted therapy, maybe something that more really modifies the disease long term. I do find that in general, I don't have a lot of people that come back with significant rebound, which is great. Because sometimes that can be hard if they did well on Tepezza and they want to do that again, they get insurance approval, because it is, an 8 course treatment. So, anything else would be off label, and insurance companies don't like to do off label things. But sometimes that can be approved and people tend to get better after that. And but yeah, we need to look, long term, and there are things coming down the pipeline that, some of them are similar to Tepezza, targeting the IGF-1 receptor. Some are, interleukin-6 modulators, and there may be some others as well. Because the immune system involved with thyroid eye disease is not fully understood yet. It involves both the B cells and the T cells, and we feel like we got a targeted therapy, which is great, because generally the side effect profile with Tepezza is remarkably pretty good, and most people are able to do that without any significant detriment.
Great. Thank you, Dr. Hayek. And Dr. Ramesh, I'd like you to comment on that and then kind of dovetail that into our next question, which we'll talk about some of the promising new therapies that are coming down the pipe,
Yeah.
you know, in the
So
future. So both, if
there's
you could do
so
both
much
of
to
those.
say about biologics.
I
Yeah,
know.
there's so much. You could spend 10
Wish we
hours
had more
talking about
time.
it. You know,
Yeah.
so first of all, every TED patient has a ticking clock inside them. That's what Rendell's curve means. So on average, people have that clock tick for 2 years, maybe 3 years before the disease goes into quote remission. But that's not everyone, and that's not everyone for every part of their TED. So maybe their proptosis is not going to get worse. Maybe their inflammation is not going to get worse, but maybe their double vision gets a little bit worse. So all of these different parts of TED, the bulging, the eyelid changes, the facial changes, and the strabismus have different time courses. And for some reason, in this disease, that clock runs down at some point for most people. But there are 10% of people who have progressive or lifelong disease. So when someone shows up in your clinic for the first time, you don't know, are they the 90% who's going to go into remission, so to speak, at 2 to 3 years, or are they going to be someone who has disease for much longer? And we have clues to help guide us. Older patients, male patients, patients who smoke. These are things that, may make your disease more progressive, but we don't totally know. And that's something for us to discover as a field. So with that said, we want to time our treatment so that we can get people at the worst part of their disease before they develop really significant things like fibrosis that's very hard to treat afterwards. So with biologics, Tepezza, teprotumumab, is an IGF-1 based therapy. That means it blocks that receptor, which is stuck to a receptor called the TSHR receptor on the cell surface of the orbital fibroblast. So the orbital fibroblast is a precursor cell in the eye socket. It differentiates. It's like a stem cell. It differentiates into other types of cells, fat cells, muscle cells. It calls other inflammatory cells to come to the eye socket and make redness and pain and swelling. So it's really kind of at the center of it all. So when the TSI, the antibody that your bone marrow makes, is floating through your bloodstream and it sticks to that orbital fibroblast, it stimulates that TSH receptor, but it also stimulates that IGF-1 receptor. And that's where teprotumumab comes and blocks those effects. This is
Right.
really different from other biologic medicines that we're testing, like tocilizumab or satralizumab or IL-6 blockers. IL-6 is a chemical that recruits inflammation. It's not specific to TED. It's used in a variety of other diseases, rheumatoid arthritis, giant cell arthritis, a variety of autoimmune diseases. So it's more of an immunosuppressant that's specific rather than a TED specific therapy. There are also other biologics like anti-FC. So there are antibodies that are floating around in your system and perhaps affecting how the body recycles those antibodies can help reduce the overall antibody load. So there are other drugs that are being trialed to work on that. But again, that's in a class of steroid sparing immunosuppressive treatments. They're treatments to suppress your immune system without having the side effects of steroids. Teprotumumab is totally different because it really does nothing to your immune system, but it really is very specific for TED. The reason why it's nice to have both of these options is because both help. It is an autoimmune disease, and suppressing the immune system does work. But it also has these very peculiar things like muscle growth and fat growth that you don't see with a lot of other autoimmune diseases. So the combination of the two is nice. You might pick one or the other based on what kind of side effects the patient has, or what diseases they have, or where they are in their disease course. So someone who has a lot of inflammation but not a lot of double vision. They're just very, very inflamed and in pain. You could use an IL-6 blocker like tocilizumab or satralizumab and treat their pain and get the clinical activity score down, like Dr. Wynn was saying, and make them feel a lot better. And maybe that drug is manageable because they wear hearing aids and you don't want to expose them to the risk of hearing dysfunction with teprotumumab. Okay, that's one patient. There's another patient who is younger, and you order an MRI and their eye muscles are big. And when they look around, they're stiff. They're starting to get a little bit of double vision when they, wake up in the morning, and they don't have a lot of inflammation, but their muscles are stiff. This is a patient where teprotumumab is really helpful because we know that teprotumumab is the only one of these biologics that reduces the extraocular muscle size. So you want to target your biologic treatment to what the patient has. It's not just option A, then you move to B, then you move to C. We have to learn about what all these things are doing. So, when I see a patient, I order an MRI and a hearing test and all this stuff at the first visit because I don't know what's going to be useful in the future, right? We
Yeah.
want to be able to look back and say, and learn, because we've learned so much now compared to 5 years ago about which treatment to use when.
Right.
Now, with teprotumumab specifically, some people have regression and some people have relapse. They're totally different things. And on the Facebook groups, these get muddled because people say, I did Tepezza and now my effect is gone, or I did Actemra and now I'm back to where I started. Well, you're probably not exactly back where you started. Um, in my patients, I've treated maybe 150 or however many with teprotumumab. I keep very detailed records, and looking at my patients over the last 5 years, I know that maybe a third of patients lose some of their effect. So if their proptosis gets better by 3 to 4 millimeters, maybe they lose a millimeter. They don't go back to square one, but they don't stay at their best, which was 6 months post the treatment.
Right.
Now, there's 10% of people in my clinic who get worse. They have flare. Their clinical activity score goes back up to what it was before. Their bulging goes back to what it was before. And this is true whether I've treated them with teprotumumab or whether I thought they were quiet and I did surgery on them. There are some patients that have true relapse, recurrence of inflammation. And even if you do nothing, some patients might be quiet and then 2 years later reactivate. And we don't know why that happens. We don't know what makes that happen. We just know that in general, 5 to 10% of TED patients across the board have that happen. So
Okay.
it makes sense that if you get a medicine like Tepezza or Actemra, that a small group will require extended treatment. And it's for
Yeah.
us as a field to figure out what you're going to have to do at that point, because we can't tell you definitively, but it's nice to have 3 or 4 options to play around with.
Yeah, no, absolutely. Thank you for explaining that. And there's multiple, I guess, cytokines in the process, and we have to figure out which combination that we need to attack to be able to better stabilize the disease in individual patients. I think I'm going to turn over to another sort of longer question again. We get lots of lots of feedback on functional and integrative medicine. And Dr. Nguyen, I know that you've done some research in this area, and especially with regard to the general autoimmune disease with the microbiome and so forth. And which I know it wasn't specific to thyroid eye disease, but it's autoimmune in general. And many people on the call have more than one autoimmune disease too. So that way it is relevant to them as well. So I was wondering if you could start out by commenting on that a little bit as well with regard to your research.
Yeah, I mean, I think the unfortunately the main take home is there really aren't the greatest studies out there in terms of, what we need to do with respect to functional medicine, anti-inflammatory diets, supplements and things like that. We do know that selenium, which is a supplement that was kind of shown by a really nice randomized clinical trial to have benefit, and probably benefits those people who are selenium deficient. The trial was done in Europe and kind of in an area that a lot of people are selenium deficient. And, for those people who are, that kind of supplementation is potentially really good and helps, people with, mild active disease. But there's a lot of preclinical work, and kind of early clinical anecdotal studies that are showing that curcumin, which like turmeric and even resveratrol, may have some benefits. But really the data isn't robust enough for us to say, oh yeah, go ahead and use these things, is it harmful? And you always ask yourself that. There's some evidence that shows that maybe resveratrol is actually detrimental in terms of the iodine symporter. Uh,
Mm.
and so we're not sure necessarily, how well all of these alternative medications and supplements are really going to do long term. Is there harm in, having a healthier diet where, you might be low sugar and gluten free and casein free and just overall maybe feel better? I don't think there's any harm in that at all. And I definitely have a number of patients who sort of swear by that. But the sort of good clinical studies to show that are just not there. I think
Mm.
that's the downside of some of these things. And I don't know what
Okay.
what the rest of you have experienced with
Yeah.
that.
Yeah. If you could comment, Dr. Hayek, I don't know if I know that
Yeah.
we talked a little bit
Um,
about it.
yeah, we did talk a little bit. I totally agree with Dr. Nguyen. I have not personally seen like great evidence of, you know, th- that type of benefit out there because we just don't have, I think, the studies to kind of show that. So, I think if patients, I have patients that, will go on what it's an autoimmune diet. And they generally, if they can do that, they generally come back and report that they feel better. And, I just personally believe if people eat, I personally don't, but if you eat better and you exercise, you generally, feel better, sleep better, etc. And the only kind of, selenium, I was in an area I was kind of deficient in, I don't really see any harm in that. So, people need to take that for months to, kind of see if there's overall benefit. But I think it's a much deserved area for finding out if some of these, supplements or diets and whatnot can be helpful.
Yeah, great. Well, thank you very much for all of your feedback. I think we're going to have to move on to the Q&A session, and Dr. Jeff Kent will be leading that, and then I will come back and wrap things up afterwards. So, Dr. Kent?
Yeah, thank you. Thank you, Dr. Ramesh, for answering some of those questions real time that came in. There were several questions that did come in, and most of them have actually been answered already, either through the discussion or Dr. Ramesh answered them in the chat or in the Q&A. But one question I think is open that Dr. Ramesh, you wanted to comment on, and that is, what is the best source for patients to best stay up to date or to learn about options that are available or that might be coming in the future?
I was just only wanted to make the point of saying talk to your doctor. The Facebook group is good for emotional support. It's not good for medical advice. So I'm sure we've all had patients who have delayed care because of fears of a treatment, whether it's surgery or biologics, and went on to have a prolonged course that was unnecessary. So if you have concerns, talk to your doctor. You can talk to multiple doctors. It's a small group of us. None of us are going to be offended if you see one of our buddies, right? So see as many doctors as you want, ask your questions, but listen to your physicians for medical advice and vent about your frustrations to your friends online and in your group chats.
Not that we don't want to hear your frustrations.
Of course. Yeah.
Uh, Thank you. I'll just ask, there's a question that did get answered, but I wonder if the other physicians might comment as well. And that is, how do you stay up to date? The field is evolving very quickly. There's always studies. There's always new information. How do you as physicians stay up to date on the ever evolving treatment landscape?
I mean, I guess I'll start with that one. I go to a number of meetings that really are just folks who do what we do, like there's a society of academic orbital surgeons, and we talk a lot about thyroid eye disease because that's probably what we see a ton of. There is the American Society of Ophthalmic Plastic and Reconstructive Surgery, or ASOPers, and that thyroid eye disease is a huge topic, and so multiple times a year we're hearing sort of the newest evidence that people are coming up with, including small case series and a case report here, but also like the big studies that are sort of influencing how we practice. And so we're sort of bringing that all together and using that to treat our patients. And I know I see these guys at those meetings too. So
Yeah, it's a small society, and we're the ones that, being oculoplastics, have generally dealt with the most thyroid eye disease patients versus any other type of doctor. And it's a big issue. And, we see each other at meetings. There's peer-to-peer contact. Of course, there's companies that are invested in thyroid eye disease that reach out. And so those are in journals, where we can get all of our information pretty currently, as long as we're up to date with that.
Okay, thanks. There's two more questions. One is, I think, pretty quick, and anyone can answer it. How long can you take selenium for?
I think if you continue to be deficient, you can probably take it, long term. I don't think, it's in a lot of multiple multivitamins and things like that, maybe not to the same dosage. But usually what I recommend to patients is actually just getting your level checked. I mean, if you're not deficient, it's probably not of a huge benefit.
And conversely, there was a Chinese study where they looked at not just selenium, but also other trace minerals like cobalt and cesium and some other stuff. And those were also deficient in autoimmune Graves patients. So maybe it's not just selenium, that's the one that we have a trial for, but there could be a variety of things that our body uses to fight inflammation that you could be deficient in. So this goes back to eating healthy and making sure you get the stuff you're supposed to get in your diet.
Okay. And then one question just came in, and this is perhaps a complex question to end on, but maybe someone could discuss the interrelationships between autoimmune disease, Tepezza, and hearing impairment.
Well,
Uh,
I don't think that.
I'd like to, before I'll let you answer, Brent, but I just want to say in January for our Oculoplastics podcast, I'm going to interview a pair of audiologists who help me with my patients and also help me with the clinical trials for these TED studies. So at some point in the early spring, you can listen to the podcast and it's specific to audio toxicity of the drugs that we use for TED. So patients and physicians can listen to learn all about the details from audiologists who are involved in the clinical trials. So with that said, Dr. Hayek.
Well, I mean, I don't have well, my answer, is that it's not fully understood. I'll just say that with hearing impairment with Tepezza, there's generally two types of hearing impairment. There's a eustachian tube dysfunction, where your eustachian tube, which is, on the other side of your middle ear, can get, compromised temporarily, kind of like getting off an airplane or having to, pop your ears. That can create a hearing impairment, but it's not one that we're real concerned about. In my patients, they tend to be younger overall that have that. I generally do not see a more neurosensory, which is the one that we're most concerned about, because in the cochlea, where our hearing organ is, we have these inner hair cells, and that is a cell that does not regenerate in our body. So once it dies, that's it. It tends to be more higher frequency hearing loss. Audiograms are important. They also have to be interpreted kind of with a grain of salt sometimes, because it's not an easy test to take, and But you generally, if you have a good audiogram, will see some of this higher frequency loss, usually not substantial. I've probably treated maybe 150 patients with Tepezza. I've had a few people with hearing impairment, at least so far as I followed them, just for several months out, because you have to kind of, a lot of these side effects do resolve on their own, but hearing may be permanent. Um, uh, Sometimes patients, at least in my experience, have been more than willing to would take Tepezza again because of the substantial benefit they got with their eyes, and may have needed adjustment of hearing aid or a new hearing to help them. But the underlying mechanism, like a lot of cells that are the receptors that we're targeting, with even direct therapies, they're more widespread throughout the body, and so it's believed that the inner hair cells have this receptor and it may compromise that.
One of the other things I think to think about is, the folks who are at higher risk, what some of the studies that have looked at hearing loss with teprotumumab have shown that it's really the individuals who have pre-existing hearing loss that are at the highest risk. But that really means that, up to 50% of people with pre-existing sensorineural hearing loss will get some um ototoxicity with teprotumumab treatment, whereas only about a quarter of those without pre-existing hearing loss will get some ototoxicity. And perhaps the good news is that really only about half of patients who have ototoxicity are symptomatic at all. So, I think we're talking about two different things because most patients will actually not self-report hearing issues with teprotumumab. And that's what we learned from the two clinical trials too, is that, only about 10% of people had some hearing issues, and most of them resolved. But when we actually look at audiograms and when we, the threshold for what's considered ototoxicity, is often a whole lot lower than what the threshold is for people to be symptomatic. And so, a lot of people will get ototoxicity. They won't necessarily have symptoms, but, you know, still is that something that you want? Because, maybe 10 years down the road, 20 years down the road, that might affect you more than someone who didn't have that, so because it all becomes additive, right? So.
Okay. And Dr. Kent, were there any other, because I do have one other question I can probably ask the group, the panel, in the we have 4 minutes remaining here.
Yeah, why don't you ask your question?
Okay, all right. So I guess, and we'll see who wants to answer. I think any of you can do this. If you guys had a crystal ball and you were trying to predict the future of where we were going with thyroid eye disease, what do you anticipate? And I know we've kind of touched on this already, but if you can expand on that a little bit more of, what kind of new therapies might be coming down the pike, and how can we expect to better manage our thyroid eye disease in the future?
I think I'll take a quick stab, maybe. I do think that probably multiple drugs are going to be used together, or multiple therapies or modalities. We talked about, the IGF-1 inhibitor, being really good at that CD34 positive fiber site that, is the actor in thyroid eye disease. There is some clinical trial where, there's a drug that they're working on that might actually work for the TSH receptor, which is part of the other half of that, that effector cascade. And, perhaps that's going to be something that's important to do, and may not have the hearing loss issues, and it may not, IGF-1's on like every cell in the body. And so, we don't necessarily have to deal with that if we hit other targets. I think time will tell. I think something that's, I think cost is going to become more of an issue, or, it is a real issue. And the one good thing is that I think because of teprotumumab, this field of understanding treatments medically for thyroid eye disease has blown up. Like it's become huge. It's, the equivalent of what, those early drugs for macular degeneration did to opening that field up. And so I think we're going to make huge progress in thyroid eye disease, probably because of Tepezza. Um, will Tepezza will be the drug for it? I have no idea. But I think Tepezza launched us into a new period where we can now really start to understand this disease because there's just so much more effort being thrown into it, so much more money being thrown into studies for this drug and understanding this disease than ever before. And so, this is definitely a new era.
Okay, thank you. We still have one more minute. Anybody, Dr. Hayek or Dr. Ramesh, want to comment further?
Well, I'll just say I agree with Dr. Nguyen. I think really Tepezza has launched us into a new era because I remember prior to Tepezza, with treating patients with thyroid eye disease, and it's just frustrating for both the patient and myself overall, because there is, we're kind of limited to steroids and radiation perhaps, and surgeries, of course. But I think, it's great for what, we consider a rare disease to have so much emphasis and attention and money on it. And I think the immune pathways will be more elicited with further research, and we'll have more and more options.
Okay, well, great. We'll have that as the last word today, but I want to thank you all so much. This has been so exciting to hear your comments, and I wish we had more time to spend because I know that each one of you could expand more on each of the questions. So thank you for that. And let's see here. Please be sure for our audience, please be sure to tune in tomorrow night. We have 2 more sessions led by Dr. Nathaniel Jelinek, who is a surgeon and thyroid eye disease patient himself, whereby he will facilitate a discussion on the patient narrative and communication. And he will address questions like, how do we talk about TED to our doctors, our family, our friends, our employers? And this will be followed by another session by Dr. Jelinek, who will be speaking with psychologist Dr. Albert Friedman to discuss how we can shift the thyroid eye disease narrative from the sense of feeling powerless to one of empowerment, and how we as TED patients can reframe our experience to take a more active role in the healing process. But before we move on to the after party, where our patients will all get together and some of our healthcare clinicians and healthcare professionals, I will turn things over to Elise Pinsler for our closing comments for this evening.
And Carol, right before that happens, I'm Christine Gustafson. I popped onto your screen, making a little cameo. So I am the CEO of the TED Community Organization, and just deeply grateful to all of you for your wonderful work and for helping us as TED patients. We are just so hopeful with what we've been learning tonight. And so thank you very much for your partnership. My part is to let you guys know how to get to the party. So there is an after party that will happen at the end that you're welcome to stay on. It's for 30 minutes, and it is where you can turn on your cameras. It's for TED patients, but families, physicians, anybody interested can stay on. What will happen is your screen will go back to the lobby, and then there will be a little button that says after party join, and that's what you need to do. So, and then hope to see you tomorrow night. Carol, you've done a fantastic job. So
great. Thank you, Christine. Thanks for the opportunity. And I'm so glad I got to know, well, I already knew Dr. Nguyen, but the others, I got glad to get to meet all of you and hope to continue a correspondence in the future. So thank you.
Thank you. Thanks for inviting us.
Yeah, thank you.
Bye. Thank you.
forget how do we do this. Enter backstage.
Hello and welcome. My name is Elise, and on behalf of everyone here at ConnectTED 2025, thank you for joining us. This first ever global virtual conference was created by and for people impacted by thyroid eye disease. TED, T-E-D, TED. As the only 501c3 nonprofit solely focused on thyroid eye disease, we provide vital education, programming, resources, advocacy, and opportunities to engage and connect with other TED patients and caregivers. We invite you to explore our website, tedcommunity.org, for a huge volume of valuable information, like you have heard during this session and throughout this week-long virtual conference. While you navigate the website, we encourage you to help us continue our critical mission of making sure no one walks alone on their TED journey. Consider making a donation today in any amount to honor your personal journey or that of a relative or friend. You'll see a red donate button at the top of every page of the website. Thank you for your support and generosity. Please stay logged on now for our exciting after party. This is your opportunity to engage live with others in the community to chat, share, and vent. Thank you again. Enjoy and good night.